Paracetamol, most commonly used drug. It's centrally acting, it's an analgesic, it's an antipyretic, so reduces fever and has negligible anti-inflammatory effects because it probably works higher up in the brain and the peripheral nervous system. It's rapidly absorbed and metabolized by the liver, so you always think liver with paracetamol, so limit the amount that you're taking. So paracetamol itself, or Panadol, is 500 milligrams QID. Just another thing around preparations, paracetamol 500 milligrams is the same as Panadol, but people will pay more for Panadol because it's the brand. So it's fine taking the generic brand because it's just as effective. It's just a way of drug companies making a little bit more money. So Panadol Osteo, you can take 2 665 milligram tablets 3 times a day because it's a longer dose, and therefore the maximum dose is 6 tablets 24 hours. So I say to people, the maximum dose you should take is 6 tablets for anything, so there's no doubt, confusion. But also be warned that sometimes paracetamol is also mixed in with nasal and cold and flu decongestants, which can sometimes contain banned substances such as pseudoephedrine, which I will talk about later. So they're often mixed with other medications. Side effects, it's very well tolerated. You can get some constipation, nausea, vomiting, headache, and they're rare but serious, things like liver failure. So watch with alcohol particularly, and watch for the severe skin reactions. This is safe in pregnancy and with breastfeeding, and it is permitted in sport. So this is the best baseline one to go to. But it's useless in treating osteoarthritis pain. It's useless for treating low back pain on its own. So I don't recommend this in isolation. I might say to people, use it for a headache or for a few days, but unless there's any other, we may need to use this with a non-steroidal anti-inflammatory for the lowest possible dose. Now, non-steroidal anti-inflammatories are the most common medication that you are going to come into contact with. It's an over-the-counter medication. Everyone can get access to it. It acts at a tissue injury site to reduce inflammation and thus pain. It's an anti-inflammatory, analgesic, and an antipyretic effect, and it may impair tissue healing in the early phase, and certainly, so we avoid this in early injuries first week, also around stress fractures as well early in that first week, or fracture healing whilst fractures are healing. They can be selective, so there's the COX-1 and there's the COX-2 inhibition in the pathway, which then reduces prostaglandins at the endothelium, the platelets, and then smooth muscle and gastric mucosa. So if we're then impairing the gastric mucosa, there's a higher risk of gastrointestinal issues, and that's often influenced by the dose and the duration. So we try and limit these to the lowest possible dose for the lowest possible time, and I generally will say no more than a week. So low-risk ones are ibuprofen and naproxen, 200 milligrams 3 times a day, or up to 800 at the slow release. So I've put here the slow release forms, which are once a day. The intermediate risk, which is your indomethacin, diclofenac, and your aspirin. We move more towards, I guess, the ibuprofen and the naproxen, but if people are having side effects, we can then shift them to the diclofenac and see if it helps. But we shouldn't be using more than one anti-inflammatory or non-steroidal anti-inflammatory at the same time. Then we've got COX-2 inhibitors, which are more for chronic pain. These tend to reduce the risk of gastrointestinal issues, but they do have a higher risk of cardiac events, and these are things like celecoxib and meloxicam. Side effects, as I said, are common: headache, dizziness, drowsiness, confusion, and water retention. All can increase cardiovascular events. So if anyone's got a cardiovascular history, I try not to get them on anti-inflammatories, and it's really important you take this as the history about, if they ask, should I? If they've got a history of this, best to say no. If they've got a history of gastrointestinal irritation, again, best to say no. Even despite these COX-2 inhibitors having a lower risk, they've got a higher risk of cardiovascular events. And it doesn't mean that COX-2 inhibitors can't cause bleeding, because they still can. Kidney function, so often people, not often, but rarely people can get renal toxicity, and they can become more dehydrated or their blood pressure goes up. So often when they go into longer term anti-inflammatories, GPs will look at blood pressure and blood tests. It can exacerbate asthma symptoms. So again, if someone's got a history of asthma, best avoid the anti-inflammatories. They may say to you, I've had this in the past without an issue. That's also okay if they've had that, but I wouldn't be using any other types. Avoid it during pregnancy. It can impair the implanting fetus in the first trimester, and it can cause issues in the third trimester. So best as a blanket, avoid during pregnancy. Safe with breastfeeding, and it is permitted in sport. Now, particularly for joints, topical is better over the oral because it's got a better side effect profile. Another thing is that there is a role for combination therapy. So, as I said, no additional benefit of combining anti-inflammatories because there's a ceiling effect. But if you use it with paracetamol, it can have an additive effect where it's more effective. So often Neuromol or Norgesic, these things help because, and I remember when we were doing AFL, it was a 2 and 2. So it'd be 2 paracetamol, 2 ibuprofen. And that was really it's actually quite effective in terms of almost sometimes better than a codeine. So they get greater and faster pain relief than equivalent doses of either agent alone. So there is a role for this, and if you're going to use it together with paracetamol. So good for headaches particularly. But there's been some recent studies out saying that does long-term anti-inflammatories actually cause cartilage loss? So this is early data, but they're looking at, is this actually a good thing or a bad thing? So we're trying to move away again from oral anti-inflammatories as much as